to be here, but I never got a final answer.
Well, I make a motion to move or approve the minute.
The agenda
Yeah, the agenda, I apologize.
with the changes, yes?
Okay, also change was to move the sheriff department up, correct?
Yes. Okay, that is true. We are gonna move the sheriff's department up since they're here early. So, they are here though, but that's a good thing. And we're not waiting for another person. Okay. All right. Pardon me?
Go ahead.
Okay. All righty. So I heard a motion to approve the agenda with the changes.
Correct.
Okey doke.
I second it.
All right. All in favor?
Aye.
Aye. Okay. We are going to move for public comments. Do we have any public comments either from outside the group or anybody from the group?
I do.
Okey-doke. Pick a mic.
Yeah.
Yep.
Yeah. My name is Perry Glenn Joshua Two Feathers Tripp. I am a community advisory board member for the Mendocino Community Clinics. We just had our meeting over there across the street. I came over here, it's been about just over a year since I had checked in with the behavioral health program. And nobody knew, people heard about it in the community, nobody knew where this program was at. So I go snooping around, knocking on doors, not having to kick them in. Find out it's back there in the back, locked up, ring the doorbell. Yes, they have a program. It's limited hours. They were supposed to, over a year ago, have a brochure, a flyer, information to be disseminated out to the local organizations as well as RCS, mainly all the NGOs that they're working with, or supposed to be working with. And as of today, I went over there and they have nothing. The only thing that I was provided was a SDUT or little brochure pamphlet here at the main office that the lady gave me. And I see that as a barrier and a problem because not people have heard about it. They don't know where it's at. They go navigating trying to find out, is it this door? Is it that door? Oh, it's the locked door in the back. That's point one. Point two, with my history, I think I'm the only one probably in the room with the 30 or the 40-hour Memphis Model CIT training that I got 12, 13 years ago. That I left this mental health board then in beginning of the 2010 to go to Sacramento. I come back, I've been in town 10 years, and it's gotten worse and worse and worse and worse and worse. I don't believe that some of the services being provided through RCS are culturally competent, not to mention what I've been going through and what I have filed with the Attorney General's office in Disability Rights California, and the complaint and grievance that I just got the paperwork today. October will be a year later. So I just want to put that out there. I'm here to support the community. I'm here to look into some things that have been going on and some things that have not been going on and people getting paid to do it by contract. I don't think it's a good use of the county's money because they're getting raped when it comes to RCS contracts. And I'm a client and consumer and a member of the community for over 47 years. So I'm just putting that out there, and maybe I'll return to this board, but I'm being awaited to be appointed to the Partnership Community Advisory Board. Thank you.
Thank you. And do you have a business card or something you can leave with us, Perry? Okay. All right, do we have any other public comment? No? Nobody back behind me? All right. So since, okay, so Perry just got here. Okay. So just so everybody knows, Perry Caller just came into the room. So everybody, there's only one person that wasn't excused that I did not hear from. All right. So Lois is not here, as I said, we hadn't heard. And if she comes in late, we'll deal with that. So could I please have the sheriff's department up front, and will you introduce yourself and use a microphone?
Yes.
And you're welcome to sit. We don't have to.
Hello, my name is Sam Logan. I'm currently a patrol sergeant with the Mendocino County Sheriff's Office. I apologize. I may have not been given all the information. My understanding was that it looks like the board was just hoping to get a better understanding of how the sheriff's office can, I guess, the interactions that either the advisory board or the behavioral health unit can work with the sheriff's office.
We want to know what you're doing. Have you changed things? I know they're working on the jail, but on the streets, how you're dealing with things, how you respond.
Yes, currently, as far as I'm aware, we work closely with I believe they're best referred to as our mobile crisis unit. You may hear our deputies refer to them as 900 units. We assign them a radio call identifier. And I know our deputies work closely with them. Most of them have a phone number to phone number basis where they can directly contact any of the workers that are on at that time and either relay information about a person that may be experiencing a mental health crisis, and typically we try to refer them to those calls prior to our response. Additionally, I don't know that I can speak much in regards to the jail in regards to the new expansion, but I am aware that new expansion will be mostly working as a mental health wing, and I think that is still probably in the progress of all coming together. Additionally, our deputies and staff do and are attempting to go to further crisis intervention training. I myself have attended, I think it was approximately a 16 to 20 hour course, which I think was offered probably about 10 years ago. And I know numerous of our staff had attended that as well.
Nothing more recent than 10 years ago that you've attended?
I guess in addition to that, our deputies on an annual basis attend a yearly training in use of force, which typically has a portion of that training to address and I guess train on how to work with people that are suffering from a mental health crisis, and how to also observe those signs.
Can I ask a question?
Go ahead.
They're implementing the Blue Envelope project on the coast, and I was wondering if that had been discussed at all here.
I think I have a general understanding of was that through Chief Cervanka and something they were doing through their department. I don't have all the details on that right now. I was aware that I think that was something the county wanted us to try to partner with them, and I can hopefully get back to you with those with that answer.
Our Rotary Club was interested in helping to fund that,
Okay.
and I heard about it through him.
Yeah, 'cause we hadn't heard until Tim brought it up.
Yeah. I think that got forwarded. If anything, I can make sure, but I thought it got to Joe in an email that was sent to me from the police chief for Fort Bragg about the Blue Envelopes program. And so I can resend that just to make sure that some of the stuff, I have it here actually, just available, which is the Blue Envelope program is designed to promote inclusivity and serve as an enhanced communication awareness tool between law enforcement and community members diagnosed with a condition or disability such as autism, spectrum disorder, dementia, anxiety, and other conditions that might require additional accommodations and awareness for law enforcement interaction. That's per sentence, but there's like basically a nice synopsis of how the program works.
When did you send that? I don't remember getting it.
Like a month ago?
Yeah, on the 24th of June. So,
Okay.
I can resend, and.
I will
that way-
call you. I should be able to look back and see if I did get
Okay.
it. I
If
don't
there's
remember
anybody else
seeing
who I
one.
need to be able to attach to this, I can do that too. I can
Okay.
see, I got, Joe, Denise, Jen, Perry, and several others, so sorry about that, but, yeah, tried to include the board in that.
Okay. I
So-
vaguely, I got something. That might have been it. And I've been a little on overloaded side.
Don't worry about it.
So,
I got finished with work at 2:30 last night. Or this morning.
okay.
I saw you had a question.
Yes. I was wondering how you feel about the crisis intervention training, and how do you feel like that would be something that if you had more of that, more PROACT training, more in de-escalation, would that help you do your job better?
I 100% believe that it would. I think that any training that would be offered to the department, I have no doubt that we would do our best to accommodate, trying to arrange staff to attend.
Okay.
And I just want to add, the sheriff's office this year is sending with behavioral health for individuals, deputies. I don't know their exact titles, so I don't want to get them wrong. But for the first time, 4 will be attending the Crisis Intervention International Convention with us, which does a lot of focus on law enforcement and mental health and different national evidence-based practices that are out there. And so this year there are 4 individuals that will be attending with the behavioral health team. And then from there, I believe there is one person from the sheriff's office that's been identified to also do the train the trainer to bring the 40-hour CIT locally.
Beautiful.
It requires a behavioral health expert and a law enforcement. So Sheriff Kendall's been really good at trying to really bring that to Mendocino County. So I know that we have the behavioral health professional that has to be a psychologist or whatever to meet post requirements. So I will be going with the individual so that we can do a train-the-trainer model locally. So behavioral health has been involved in CIT and has trained CIT coordinators. And this will be the first year that we've offered law enforcement every year to go, and this is the first time that we have the sheriff's office saying,
We are
yes, we'll
very
be there with you. So they have 4 individuals identified.
When is that training?
It's in August.
In August.
That is wonderful.
Yeah.
I have one more question for
Yes.
you. Do you feel that there is enough resources? De-escalation oftentimes takes a bit of extra work. It is more, I mean, when you got someone pumped up on meth and schizophrenic episodes on top of it, and that could take hours. It definitely takes a minute. Is there something that could be done to help with being able to safely de-escalate that person rather than have to resort to tasers, things like that, that put people at risk?
I think I would answer that by saying we've seen great success by dispatching our, our 900 units or our crisis response team. And I think part of that, I guess to answer your question, is our hope typically is that their presence is a great form of de-escalation because law enforcement's presence doesn't always assist the situation. And typically if those units, the crisis units are on scene and feel like we may be needed, then we'll typically respond, but we usually are in the background waiting to see if there's any kind of crime being committed at that point.
Okay. Thank you.
You're welcome.
Or theoretically, you would want to get them de-escalated before the crime happens.
Well, that I would say is the hope of the response units. That's mostly, I think, the goal is that they're going to try to offer resources that may be better suited for those individuals rather than just to have law enforcement present. Yes.
So I'll say that for myself as an individual and for a lot of the constituents I talk to, one of our challenges is that when we notice somebody that may be under the influence or also or experiencing a mental health episode at that time, I think a natural reaction is to not want to call law enforcement and instead to want to call a mental health counselor because like you said, the approaches are so different. And so I know that Dr. Miller and the folks at RCS are trying to work on an improved response time for individuals to be able to call into our crisis hotline instead of calling 911. When I've spoken to the sheriff about it, it's kind of like 911 is our best access right now. So do you all have any feedback as far as if we go ahead and call 911 and you're not able to respond, is there a way to say, like, we're trying to get there as soon as we can, or can you might not know about the dispatch process or how quickly they can call people out, but or any feedback as far as who as an individual I should call when I see somebody that may need help?
Yeah, I think the process right now is probably, I guess, how we could say is just kind of where it's at. Unfortunately, I think other agencies across the state are utilizing or have now dispatch centers for mental health crisis-related calls. We don't have that yet. So typically, if a call does come in through our dispatch center, it's going to be fielded or looked at by probably our communications supervisor and then a field supervisor. And then, or if the deputy feels that it's more appropriate for a crisis response unit to just handle the call, we may do that. Does that answer your question?
Yeah, so it seems like a case-by-case basis. And here, just I would say for anybody that doesn't know, especially in Ukiah, it can be a little bit challenging, especially since the majority of us don't have landlines anymore. And so sometimes your first call is going to go to CHP dispatch in Reading. And depending on your location, you could get the sheriff's office or you could get Ukiah Police Department. So just because of the way 911 calls in particular go out, it's a little bit more of a challenge. And I know we've talked about in the past really encouraging the community to call the crisis hotline first, especially if it doesn't look as if there's a crime being committed. And so just a process improvement, I think.
Yeah, and I think there are times when the crisis dispatch center may end up forwarding that call to us at the end of whatever information they get. And then again, we go through kind of that process to see what would be the best response to that call.
If a 911 call comes in, because it's easier to remember 911 than the 800 number, if somebody calls and it's somebody you know that experiences these breakdowns, or if it's something that sounds like, do you then call crisis if you don't use your own people, or do you call crisis and ask them to come as well?
Yeah, I think typically our process is to attempt to contact our response team. They work closely with the crisis unit as well, and vice versa. Typically, we won't reach right out to the crisis unit that I'm aware of, but I mean that definitely could be something that could be helpful in the future if that seems to be working better.
And Joe, just to clarify, when he says his response team, it's the county behavioral health crisis response team.
No, I get that.
Yeah, just to make sure you know, it's our team that works alongside their
Yes.
team, so that's why they're
Did everybody else realize
instructed to
that
call
too?
us first. Yeah.
Yeah.
We're the mobile team, so their 900 team or mobile
Right.
team, we have police radios, so they can call us through the radios or cell phones.
So you would be calling crisis. So you would
We
Yeah.
don't, we'll call crisis and let them know if we're bringing a 5150 in. So that's the communication. We'll make that decision and then we'll notify them that we're bringing a 5150 in.
And one more question, and it's sort of a capacity issue. Is there enough support through the mobile crisis unit we have fair amounts of incidents in our county. Do you feel that there's a fair amount of personnel and ability to serve that need alongside of you? Or are there things that we could do to improve that to help?
I would definitely say, probably just like every department in the county, we could use more staffing. There are times when the people that are on are in different parts of the county, and the response time is very, expanded or elongated. So I would say yes. I think more staffing would always help because it does expand the call time or the response time.
Right. Okay. Thank you.
Do we have any more questions? Any more
Cute, my pen burned.
that you feel that you want to share with us?
I don't have anything at this time. Thank you, though.
Kind of got put on the hot seat
I
today.
did, yes, but thank you for understanding.
We thank you so much.
Oh, you're very welcome.
Because I think Sheriff is not there, and he was going to send somebody. It sounds like it was just kind of...
Correct, yes. So
Okay. Well, we appreciate you being here and being on the hot seat.
you're very welcome.
Nice to meet you.
Nice to
Yeah.
meet
It
you.
is we hope to see you again. Maybe, are there people in your department that are interested in this?
I'm sure there are. Unfortunately, we don't have any specific titles or positions that are assigned to, say, the mobile crisis unit. But like I said, our deputies work very well with those units. They most of them know each other by first name, and I think it's come a long ways of utilizing that system to assist with the community that suffers from mental health illness.
Thank you.
You're welcome.
It's a learning curve for all of us, and it's getting better.
And thank you, Dr. Miller, for the other side of it.
Thank you.
Thank you. Okay.
Thank you for coming.
We'll get Sheriff Kendall for you. All right. So the next on the agenda is the approval of the last two meetings' minutes. We have minutes from our meeting on the 23rd, which was a special meeting, and then we have minutes from last month's. So let's just do one at a time. From the June 18th meeting, is there anybody that wants to approve the minutes? Are there any changes that anybody noticed that we needed to do?
I move that we approve the minutes from June 18th meeting.
Okay.
I second it.
All right. Anybody else? All in favor? Aye.
Aye.
On these? Anybody opposed? Okay. The minutes from our June 23rd meeting, which was our special meeting that we had in Fort Bragg. Are there any changes or questions regarding this? Thank you for being here.
Thank you very much.
Is there anything else that anybody wants to change or add?
Then on that part, can I make a motion? I wasn't at that meeting, or
Yes.
You sure can.
want to make a motion to approve it without any changes?
Okay. Do I hear a second?
Yes.
All righty. My only question is we were supposed to have our vision statement with this? I'm sorry, you haven't been busy at all.
Yeah, I mean, I probably can pull it up.
I thought it was in the minutes.
Well, we did actually approve, you guys did approve it at the.
And I think it's in the minutes, right?
I didn't see them in the minutes, but that doesn't mean that they're not there. I saw mention of them.
It's right here.
Yeah.
B.
Of the 23rd.
Okay, good. All right, and that was what you had rewritten.
Yeah.
That was what had been rewritten. Okay, cool, because I'm,
If anyone wants to see, it's under 4B.
yep. Found them, 4B.
Yep.
All right, so
Beautiful.
any other questions or changes? So all in favor of approving these minutes, say aye.
Aye.
Okay. Yeah, I know. No, we did that, and then, the reason, this all got rearranged because, no, I know that. I know that, so, we moved everything around because of the police department. Okay, all right, so Dr. Miller, would you like to do your report next?
Sure, I will try to not take forever, but I will give some status updates.
Well, you've got extra time now.
I know I was gonna have extra time. Remember you told me to sit in a short amount of time, so law enforcement had enough time.
And then they
so-
didn't show up?
So, yeah.
All right.
So yeah, Ukiah Police, they needed to reschedule for August, and then Fort Bragg Police will also be at your August meeting. So you'll have both, Ukiah Police and Fort Bragg Police at your August meeting. And then, we're working still with Willits Police Department, so hopefully they'll be able to come in September. So, you have my director's report. If there's anything in there that you guys have questions on, I'm more than happy to, report out on that. It's kind of the standard stuff. We did, all of our, especially mental health contracts did pass with the Board of Supervisors, so we, are moving forward with a new year, with a lot of changes happening, at, the federal and state level. And, the state has been going through a lot of changes over the last, 2 years, I would say, just about, really changing a lot of how we do stuff and different requirements for county behavioral health department, and with the rollout with Behavioral Health Services Act, or BHT, how it's got a couple different names. We're going to continue to see a lot of changes and movement on where we're going with especially mental health and what that looks like. So be patient. Your contracted providers, every time there's a change, they have to change. And every time something new comes down, and then we're telling them, oh, now we're doing it this way. And so there's a lot happening. There's a movement towards evidence-based practices more than we've ever had at a level, especially for the focus on youth. And obviously some additional focus on forensics populations. And so we'll be working with our contracted providers to start looking at some of that. We've had PCIT in Mendocino County for, I want to say like 17 years, but so PCIT is one of the evidence-based practice for the youth side of the house. We've had PCIT forever. So that is something some of our providers have trained, but we'll be looking at really working with the new evidence-based practices that the state wants to roll out and making sure that providers are trained in those. The state is creating Center for Excellence that will be actually looking at fidelity to those models and working with counties to come in and assess to see are your providers providing those services at a level that meets the fidelity of the evidence-based practice. So a lot of change coming and a lot more auditing and oversight. The state is also moving to more sanctions and fines for counties that aren't in compliance, where the state thinks that counties need to be in compliance. And some of them make sense, and some of them can be a little over the top when they want to say how many providers you should have of one type within your county, even though you don't have the clients to serve them. They still expect you to have you know, 10 psychiatrists, even if you only have enough clients to keep 3 busy. So there are some standards that the state is really looking at. I think the counties are pushing back on some of it, but really working on, you know, how do we meet those standards. Small rural communities like ours, some of those evidence-based practices may be tougher to roll out. And so we'll be looking at how do we do that and how do we meet all of those state mandates and requirements that are coming down, and making sure we try to get everyone trained. We also know that, you know, there's a lot of changes happening at the state level. I can't speak yet to all of the changes. I think that there is a lot unknown on how everything will impact our system. We have seen some impacts to our system that we know where we're being told you're no longer going to have this funding. More so on our public health side of the house, we've seen some funding changes happening with our CalFresh Healthy Living Program. That'll be not funded after September 30th. At this point, the state is not going to be able to come up with additional funds for that. So we'll continue to see some changes happening. And I think the big thing for us is as changes happen within the system, it impacts your clients. So we do see an impact on overall health and an impact on mental health for individuals that have been used to having services or access to certain things that they'll no longer be able to have access to. So it is something we're watching on a level. We're watching to see how the UIS, unsatisfactory immigration status, that is at the state level, how that will impact coming next year in January. And the requirement for people to re-enroll every 6 months. It's sometimes very hard for our clients to meet the enrollment once a year. And so this will be an additional thing. And the work expectation at the federal level of 80 hours a week. And so we're watching to see what does able-bodied mean. Will our clients still qualify under the able-bodied terminology? Will they not? Will some qualify? Will they not? Because that will impact how we work with our clients and how we try to work with them to make sure they stay on their Medi-Cal and meet whatever requirements that are coming down. We are working with our providers, both our special mental health providers, substance use providers, and our health clinics and hospital, because the impacts kind of will impact everybody as we see some rollouts on those. Just some updates on things that become effective immediately. And upon enactment, and I don't know how many people are watching to see some of those changes, but they will hit our social services departments in addition to our healthcare departments. The expanded SNAP work requirements are upon enactment. The SNAP standard utility allowance is upon enactment. SNAP treatment of internet expenses upon enactment. SNAP immigration eligibility upon enactment. Moratorium on Medicaid and children's health insurance. The CHIP streamline regulations is upon enactment. We'll see the SNAP Ed program eliminated October 1st, 2025. There's so many dates, but I want to talk about what's immediate. There was a new regulation that came in about use of federal funding for individuals that have a UIS satisfaction, that you cannot use those federal funding if the program receives federal funding. Several states have filed a lawsuit and asked for a motion for injunction, so we're waiting to see what happens with that. We do serve in our community a decent number of UIS individuals, so we're waiting to see that impact. As people probably know or don't know, federally qualified health clinics are required to serve you regardless of payer, being able to pay. Hospitals, due to EMTALA, are required to serve anybody regardless of pay.
In the emergency.
In the emergency room. County services. There's requirements in county code that says counties will serve the indigent up to funds being available. And so there is county code that requires us to serve the indigent health. And so if we lose funding, we'll have to come up with a way, depending on how things roll out, of how the county looks at potentially funding services that we don't have funds to serve them anymore. And so that's, I think, where a lot of counties are really especially in California, are looking at what does this mean. California, as we know, the state operates a little different than some other states, where the state puts a lot onto counties to operate and run their different systems. And so the counties sort of carry a burden that maybe other states might not have because the state would meet those mandates. But that doesn't mean other states aren't going to have similar issues in California. We also will see some changes in reimbursements, so we're waiting to see how those reimbursements roll out. There is some changes of what the federal government will pay versus what the states will have to pay, especially in the SNAP programs. And so we'll have to see how those roll out and impact our communities and our clients as we see those changes coming forward. I don't think anyone has a crystal ball, so I don't think anyone can predict any of the changes at this time, and I don't think anyone really knows what the changes, but we'll have to watch and see them as they come forward. So I wanted to give, yes, sir.
Are you working with Adventists? There is going to be, I believe, a drive to emergency room increases in visits as we go through this, and that's the last stop. And so that will impact us because a lot of our holds are in there, there was one time where I talked with them about the old ER could be used perhaps as a psychiatric ER, which maybe would take that burden off of the emergency room in Ukiah. Maybe that would be something at some point to talk about, because I think that is going to become a huge impact.
We are meeting, we've been working with Adventists and the clinics. We meet monthly with the Health Care Coalition that's been developed to really work on, what really we were focused on better health outcomes for Mendocino County. And I think now we're still working on that, but a little bit of focus has changed to also what are the impacted services. We just, I read, that I heard that, some health agencies have done some layoffs of medical staff, nurses. And so, not locally, but some stuff I was reading. So I do think, we are working with Adventists. We're working to see how are we going to make sure that we keep our health outcomes still good in Mendocino County. We do know when people can't get into primary care, they go to the emergency room. And we do know if the emergency room can't bill for that, it's a cost they have to endure, which then either puts them into a negative or they start having to charge more for those who can't afford to pay, right? So we'll have to see how that all plays out, but we are talking about how are we going to work to make sure people stay on Medi-Cal, those that can, especially with that rolling 6 months re-enrollment potential, to making sure we don't lose that benefit and locally either. And we know that the last time I checked, our number of individuals in Mendocino County, 46% of our population was on Medi-Cal.
Yeah.
So that's a high number when you think 46% are on Medi-Cal. And there's a question on how many of those would not be on Medi-Cal with some of the changes, and I can't answer that. I don't know that anyone can right now. So some things that we're trying to look at and work with our partners and make sure we're serving the communities we need to serve and still trying to meet all the mandates. So that's a little bit update on our federal stuff. I'll keep you guys updated as I can. As we learn more, and I think we'll probably know more towards the end of the year what the state's doing versus how the federal impacts. Of course, if we have all these court cases and injunctions, it might be next year we know more of what our system's going to look like and how things are going to roll out. But we definitely are watching it, and we are watching as different things come up, and we hear we're going to lose some funding. So, we know we've lost a couple things where we've been told we're only going to fund you at 70%, not 100%, or we're not going to fund you at all. So we are really tracking that to make sure that our budgets are maintained and that we're able to still meet our mandates and do all that. We meet with our providers quarterly, individually, and then as a group. And so we've been working with them, preparing them for changes with behavioral, the BHSA, BHT. and also been working with them on preparing them of, we don't know what the federal rollout's going to be. We don't know what the state rollouts are going to be. They are prepared that we've talked about we may have to reduce contracts. We may have to look at how we serve people differently. Those are things that we have been talking with our providers about to keep them up to date as much as we can versus and hear what they're hearing. So I think we're all kind of in a holding pattern at the moment, waiting to hear more about what's going on. Any other federal questions?
I have a question.
Yeah.
I've heard a little bit about there being a renewed effort at the federal level to strengthen the certified behavioral health clinics nationwide, but California has not been open to that concept, even though it's been talked about for quite some time. Have you heard any?
I
movement there?
haven't heard anything from the state level at this time. I think the state's really, I don't want to speak for them, but I think they're so focused on BH Connect and all of that rollout that's really where they're focused on right now. So we do have waivers, 1115 waivers in California. I think some of us know that. A handful of our waivers will come up in December 2026. And there is a change in how waivers will be looked at going forward from the federal level. And so we will be interesting to see how those waivers come forward. I was going to read the language because they have some language about waivers if I can find it. Right here. So they're called Medicaid Section 1115 demonstration waivers. So the change that we'll see is must be determined by the Center for Medicare and Medicaid to budget neutral for approval. This applies to waivers up for renewal. And so that will be a big thing we see change to the 1115 waivers is more of a budget neutral, where a lot of 1115 waivers allowed different states or waivers to expand services beyond what Medicaid would normally pay for. So that'll be a change we see in the next starting in January 2027 is kind of when that.
So that might impact things like wellness programs. And
it would impact whatever comes up on the 1115 waiver. And so your waivers are usually good for 3 to 5 years. California has some waivers that it just got approved in 2024 that will go to 2029. I haven't heard anything about them cutting current waivers. It's more about waivers that are expiring. So some of our waivers that are set to expire, and I don't have the list up, but your drug medical organized delivery system, so the expansion of substance use treatment and the payment for detox and residential, that's our waiver that ends in December. There's a couple of different waivers that will come up, and I can bring that list back.
Could you bring that, because that, I could see that causing us big problems here.
Yeah, I can bring, I'll get that list of what are the ones that we can expect that could not be renewed. No one's saying they won't be renewed. They're just the ones California knows is up for renewal.
Okay, thank you.
Anything else on the federal stuff? All right. So the other thing I wanted to talk about was the puff. If everyone has seen it, it's going great, and it's looking better every day. It looks more like a puff every day. We've been working on colors. It's always an interesting experience on colors and our handles and all of that stuff. But last update, we know it might be delayed due to the electrical switchgear. I know that they are trying to fast track that, and that the facilities team and the construction manager will be at the Next Measure B meeting to kind of give an update. Hopefully at that meeting they'll have better time frame of when they think construction will be completely done. I have been told they are working to do everything they can, so that all they have to do is that last piece. And so they're going to get it as far as it can go until that last piece comes in, and they know that they're working hard to try to keep it, try to get it done as soon as they can. I did recently learn that there was another facility that got delayed also because of electrical switchgear. So I guess it's a common part to be a little bit behind. And the state has been telling us for a while now that a lot of the
grants that they sent, a lot of the projects that they gave grants for building have delayed due to something. So, on the build thing, something with getting parts and delays in that area. So it's not a contractor delay, it's a part delay at this point.
The other facility that you heard about, did they finally get their switchgear since they're farther down the pipeline?
Yes, they got their switchgear, but I'm looking at Tim because it was Anchor's Mental Health Rehab Center that's about to open, but their project also got delayed because of their electrical switchgear. But I think it put you guys a couple months out, right, Tim?
Yeah, it's continuing to be a little bit elusive as to the completion thereof, because of, you know, once the building, then there's a bunch of inspectors that have to come in and permits and occupancy things and all of the state certification. So there's a lot of moving parts that we are.
But the switchgear got there.
The switchgear got there, yes.
Okay.
But it delayed them a few months because of the switchgear.
What we're awaiting now is there's a hood thing that goes over the kitchen that is not available right now. It's full of like fire provision.
It's called an anvil unit.
Features and everything. It's pretty complicated, but that's what one of the things we're waiting for, plus a bunch of finishing and touches and forever going on.
But yes, they got their switchgear. That's just, there seems to be, what the state has said is that there are a lot of delays from the perspective of finding stuff. So we're not the only one. So is it okay if I move on? Any other questions on my part? All right. Electronic health record, we had talked about keeping you guys updated on the electronic health record. So we have 3 providers going into our electronic health record avatar. And the new PUF operator is also going to be looking at Avatar, whether it's something they can use. So if it meets their standards, they're happy to go into NetSmart Avatar, which I'm excited to hear. So we've been working with Tapestry Youth Project and Hospitality House and getting them trained and getting that system up and going. It's a lot of work to move to a new electronic health record. I think we've been putting dates together, and I think everyone's like, whoa! But we have it up. It is pretty operational. We're in the training phase with those 3 providers. And so we're super excited to do that. The county we've been talking to both Anchor and RCS, we're not going to be doing data entry at a certain point. And so we have been trying to get their interoperability in place. That's not in place yet. But we will not be able to do data entry as we have to start taking over billing for the whole county. So they do have subsystems into Avatar for certain features. We're working with them they've got to figure out their interoperability, because at some point between September and December, we will have to cold turkey doing their data entry for them. And that's currently what happens. They send us
And the billing department is going to be doing that?
The billing department has been doing that.
Oy.
So we have to stop doing that.
Okay.
So which is why we went to Avatar, right? Is because what happens is it comes in and then we have to put it all in ourselves. And so with them going into Avatar, it stops that. They send it up in Avatar, and then our team doesn't have to do anything but inspect it, review it, make sure the code looks right and stuff. The 2 providers who aren't going into Avatar, we haven't got the interoperability built in yet, but we can't continue to do the data entry for them. So we've let them know. At some point they will have to decide what they do, whether they have double entry into both systems, because we won't have the staffing to do the data entry for them. We're taking on billing for the jail, the sheriff's office, public health, and helping social services with one of their programs. And so we're not going to be able to have the manpower to do the data entry. So that's just an update on the electronic health record where we're at. I think we set a new date of mid-August. In August, yeah, for having the 3 providers completely up and running in the system.
And you will maintain a quality control in the billing department still to make sure.
Correct.
Perfect.
That doesn't change. We're still
Okay.
mandated. Our error rate is really low. I mean,
Yeah.
that's something.
And I don't want it to change.
No, that is something we get a lot of credit for whenever we get audited by the state. Our error rate is way below the 3%. Usually it's below the 1%. And so we get a lot of kudos from the state of having such a low error rate. The federal government believes it should be 3% or less. And so we definitely stay within usually a 1% or less error rate with our billing. So we will continue to make sure we have complete oversight, auditing, review of that. What will change is we won't be able to do that double entry, putting the data in.
Good.
Yeah. So, just an update on that, because I know I try to keep you guys updated, and we'll have a party when we get everything, when the 3 providers are completely in. And then we move to getting sheriff probation fully in, which hopefully we're hoping to have, working with them in our interoperability where the sheriff's office system will work with Avatar so that we have all our records through the sheriff's office, able to maintain their records, and we're able to do billing under the state seamlessly. So more to come on that, but that's...
Does any of that interface with Epic?
Not currently. You can build interfaces, which is interoperability. So you can build those interfaces. They cost to build interfaces. But what the state has really pushed and what we work with, we have a health information exchange. And part of that, so your HIE, which is Health Information Exchange, pushes the client's chart up. And then if that client is in another system, it pulls it in if they're part of the Health Information Exchange. So if the hospital is part of the Health Information Exchange, the client's info goes up and back down. And so we use the same Health Information Exchange as partnership. Specifically, we partnered to make sure we kept that, because being that partnership is our main managed care plan, it works with everything. It allows everyone within the partnership system to be able to up and down their health information. And so we're part of that. The only part of data that is tricky with the HIE, there's still some public health stuff that the state's working on in substance use because of 42 CFR.
Right.
They're trying to, state is trying to come up with kind of a universal consent release that would release that part of the substance use to meet 42 CFR. So we'll see.
Will you keep us posted on the universal consent release? Because that, I think, is going to be key in the flow of information and treatment in the county.
Yeah, so, yeah, I will. We'll see what the state is looking at that. We're also looking at locally doing a memorandum of understanding, which would then create a business associations agreement and a consent decree for all of our providers that say we're part of the Mendocino Healthcare Collaboration, and when you sign this, you sign for us to work with all of our partners in the county. That's what Healthcare Collaboration is working on. So outside of what the state's doing, we're also trying to do it globally. I've heard we're supposedly the only county that's kind of doing that as a full collaborative locally. So we'll get one way or the other. But we are watching what the state is doing on that. And just a couple other updates. We rolled out a county-based Medi-Cal administrative activities, which is called CMA Mendocino County. We took that on through the public health department. And it is an alternative billing. It's administrative billing for Medi-Cal, which is through the feds. You have to actually go through a process to do that. And we've been working with county partners. I know we will probably look at, we're also started rolling out mental health law, which is a subcategory of CLAW. And we're working with county departments first to get it up and running, probably work with community-based partners going forward, but really trying to get that up and running in our county. We've got it rolled out right now, the CMAW portion rolled out in our social services department, in our public defender's office, and our OES department, and then in public health. So it allows us to bring in additional dollars that Mendocino County has not been tapping into. Some counties bring in a decent amount of dollars through CMAW, and so we're really excited. We're working with social services and their VETS program, their public guardian program, and their APS program. And the nice thing is that we were able to do some work with other counties, and we were able to determine that in our VETS program it's 100% general funded. And so we were able to work with one county who the first year they brought in like $50,000, and now they're in the up to $100,000. So really trying to work on how do we help stabilize some of our general fund programs and our programs that could bring us in this additional funding stream. So we've been working with a couple of the different general funded programs
So you're billing out for the public defender, social worker, and that type of these support services?
So they'll time study to what's called, they'll do a time study for CMO activities. My staff has built the program, and then we will check their billing, work with them, and do all their billing. It's about a 15-month lag from the first time you do it, but once you do it, then you're bringing it in. Then you're bringing it in more regularly because you can go more regularly. But yeah, so we implemented it through public health, behavioral health, to one, bring it into our programs and work with all the county systems that can bring it in, and then potentially expand to community partners.
Perfect.
So just an alternative fund stream we have not been tapping into, which I'm really excited to bring that in.
What is CMAW?
It's called, it's county-based Medi-Cal administrative activities. The feds call it something else. You know, California, we always rename everything. So the feds call it something else, and I can't think of the name right now, but it actually has to be billed through your county. So your county is your LGA. So it goes through your county system, and then it can roll out. But it's specific for Medi-Cal or Medicaid activities that are more kind of on the administrative side of like educating people about Medi-Cal, getting them enrolled in Medi-Cal. It's those additional features that you can kind of do the billing for. So we've never done it really well in Mendocino County. We let it go. We started it, let it go. And so it's something we're taking by storm now and really saying we're going to do it and really change and bring the additional dollars to the county.
I think it's very smart.
We might need more staff at some point, but we're taking on a lot.
You'll be paying for
We're
it.
taking on a lot. There's alternative things, but that's good. We also we are working on a Path Justice Involved implementation for the county. That is part of the electronic health record we're doing with the Sheriff's Office and probation. I think you guys know one of the things that we did on the public health side. General Hall was losing their providers, and so we stepped in to provide all their medical care in the juvenile hall. And so we've been working with that, and then we had to step into some clinical side of the house for them from the behavioral side of the house, and we do some substance use sources there. But Path Justice Involved is part of the CalAIM initiative to be able to build Medi-Cal for individuals and get them actually served 90-day pre-release. And so we've been working with probation and the sheriff's office to really get those services up and ready with a go live date. If this is tentative live date January 2026, we might have to push that a little depending on electronic health records and stuff like that. But we are working with them to get systems in place and to get electronic health records in place to be able to really get them up and going and being able to bill Medi-Cal. So we're, with the Sheriff's Office, we're working on getting interoperability with our electronic health record. We'll be doing billing for them and working with NAFCare as their medical provider and to really get those services in place. So that's just an update. We're hoping January 1st. Of course, that could end up being probably March, April. So it's just another thing we're taking on to also use like the Avatar and then do it just So, did you want me to talk more, Joe?
No, you're moving along well, though. I just want to say.
You have more you want to tell us?
No, not that I know of, but in case there is something else you wanted me else you wanted me to say. There's a lot we're doing. But yes.
Can you talk about staffing? I do see that there are some positions on county job board. I see we lost one. I know we're keeping track now. Across the country, across all of our agencies locally, we struggle to keep staff, and especially when we're having these budget challenges, we don't really know what's happening next. So how are we doing with our not hiring freeze part?
With our strategic hiring.
Yeah, I mean, I am one supervisor, and I just personally think that it is important that we hire for positions, especially when we have other funding resources besides the general fund. So can you talk a little bit about where we're?
I think that in all transparency, I think it's very hard to hire in Mendocino County. It's hard to get certain levels of staffing that we need, meet some of the MQs that we really need. And that is hard. I think, you know, I know our providers, I know us, we've tried to do a lot of internship programs, really trying to encourage interns to come to Mendocino County. We've talked about working as a partnership to create more of an internship with a stipend that might encourage people to come. It's hard to find the stipend. But you know, when you're in graduate school, you're looking for the internship that pays a stipend. I mean, why not, right? And so that's where you're going to go first. So we've talked about a consortium where individuals could rotate between agencies, because sometimes you don't like one agency, but you find you're in another agency because they do something different. And we've talked at the clinic about that inside. So those are just some strategies. We really struggle, and no one wants to hear this, with pay. You know, we don't pay competitive to Sonoma County.
Nope.
And, you know, and I don't take offense to this, but sometimes our providers pay better than we do. And so if your providers are paying better than the county is paying, where are they going to go? They're going to go to your providers. And we want our providers to be staffed too. But when there's positions we need to fill, and they have a choice between making, you know, $3 to $5 more with a provider than the county, they're going to go there. And not that we want them to pay their staff any less, but it is a challenge that the county faces. I think that from our perspective, I don't think that we're putting every position through that we probably need. I think we're trying to be strategic with what we can put through and the process to put through, because there is a process to request a position. And so I think that we are holding back on putting through every position that we would probably like to put through.
One of the things that's a limit is psychiatrists, and I know there's going to be more of a requirement for that. One of the things that I was talking to physicians about, maybe doing a rotation, a Stanford rotation. We have interns at a hospital. Maybe we could get psychiatric internships.
It's hard to do, so yes, we thought about that, but if, for anybody who's worked with individuals in the field or have a loved one in the field, you probably will have learned that the worst thing is when you go see a new psychiatrist, because they want to change what their clients meant. Every time they see a new psychiatrist, they change the meds. Even if they're doing well on their meds, they change the meds. So, you know, it's hard when you start rotating, then client experience that med change on more of a regular basis. And you know, I worked with some companies that, you know, that's what they do. They'll contract with counties to provide additional psychiatry. And the question I asked is, what do you do about med changes? You know, and most of them said it's up to the doctor. I'm like, yeah, but here's my experience, right? I don't want every 3 months or 6 months to have my clients get a new doctor who's going to change their meds. If they're not working, great. But if they're stable and then you cause them the decomp and they need to be hospitalized because you decided there's a new med on the market and it's better, that doesn't benefit the client. But you see this happen on a regular basis where they want to change the med.
That is so I totally get that perspective. Maybe we shouldn't be talking internship. Maybe we should be talking residency. We have a residency program. Residents tend to stay in a psychiatric residency. You're talking about 2-year longevity, and we might be able to pull those people in.
Yeah,
So
I mean,
you
it's
might
definitely
have a little more
something to-
control
yeah.
in residency than you would in internship.
It's definitely something I can look into. Like I said, I've tried some of the different companies that kind of, you know, say, oh, we have doctors, you can see them, but they can't guarantee a doctor for a year or even 2 years.
Right.
To get who we have. And so I'm just not willing to put people through that. You know, I need some stability for clients. We want clients that not decompensated. We want them to be stable. Their meds are so key to that.
The one thing I found in veterinary medicine, because you'd have sales reps that would walk in with the new and better,
They don't do that so
and
much anymore.
what they end up doing is, see you later, Mark. What they would do is they come in and give them incentives for their salespeople to sell the new product also. And so it's whether they capitulate or they just...
Well, it's happened, you know, we used to get salespeople here all the time too. And there was an example, and I won't say the med, there was an example of a new med came out and they were selling it as a new Clozaril, right? The new Clozaril. The new Clozaril, it's just as good as Clozaril. It's going to do everything you want, better than Clozaril. It doesn't have all the side effects, you know. And we were like, oh no, right? Because we just knew everyone was going to get changed. I guarantee 3 months into the new Clozaril, we started seeing all these people that had been stable go into crisis and need to be hospitalized. And we started asking, first we didn't, you know, it was like, okay, what's going on? And then we started asking, what? Did you have a med change, right? So we started looking at, really analyzing what happened. And everyone was getting changed to the Clozaril that wasn't working for them. And we probably had a good 15, 20 people over a couple months get hospitalized because of med change. That the new Clozaril wasn't as good as the old Clozaril, right? So it is unfortunate because they do sell it. But I think any of us that have been around enough to work with a psychiatrist, do change their meds.
Well,
And sometimes they go to the hospital, they get a new bed, they come back, they see their psychiatrist, and they change them from what the hospital put them on. And you're like, stop, why?
I mean, it is mental health as a psyche. I mean, that is the physician in the mental health system. And mental health is a healthcare system. It's not an ethereal system of social services. It is an actual healthcare system. You are billing insurance for medical products. So there, I mean, at some level you do have to interface. Even the PAs that are prescribing are working under a doctor. I mean, it's not just magically happening. And so sometimes, I mean, these people are professionals. Sometimes you have to see who's doing what. I mean, DRW is a staffing agency that specializes in psychiatry. I've seen some very good physicians out of them. You know, it depends on who you're using, but it is a medically driven system.
I can tell you, I talked to almost 10 different agencies that do psychiatry. And I think I only found one who could guarantee me they wouldn't change meds every time they saw a new doctor. But at that point, they weren't taking on any new counties.
You feel like you're caught up?
Yeah, I think so. I'm sure there's more if you want, but
Okay.
any other questions?
So, are we ready to move on to board and committee reports? So, I moved the minutes up just so you know. It looked like it was confusing, but I knew Mark had to leave early and that was something we needed to know, we needed to take a vote on. So, and we have nothing else to vote on now. As far as we were going to have Lois here, but she wasn't, I guess, able to make it, and I'll see if we can get her here for next month. Hopefully Martin will be here. Martin had to take a client out of town and to a special hospital, and so I thought that was much more important than being here. Then as far as discussion, Elsa and I must have had a miscommunication because we were going to have a discussion and vote on that vision statement by itself, but we have.
I think I know what the confusion was. When I was speaking, we were saying, we had a suggestion of what it was, but we didn't vote on it. When I went back and looked at the minutes,
Okay, well, we didn't finish the communication, so that's okay. It's all right.
But it is on your agenda, Joe, where it says discussion and vote on vision statement.
Right.
So, but everyone can look at the vision statement in the past.
Right, but at the time we were doing the agenda, we did not realize that it was in minutes already as approved.
Right.
So,
Well, you could take a vote on it if you want everyone who wasn't there to have an opinion.
we can. Does anybody, there were a few people that were not there, and we do have time. The vision statement was something that we came up with during the meeting on the 23rd of June. And it is in, I believe we said it was 3B? 4B. Those minutes. And we can read that and we can pull it out. Sorry. So we did a vision statement and it got fine-tuned, and I'm willing to read it. If we want to vote on it separately, I have no problem with that. So our vision statement is as follows. We support recovery and wellness for Medi-Cal beneficiaries with serious mental illness or substance misuse disorders through compassionate, culturally responsive care, working together to reduce disparities and strengthen our community. No,
Good.
there was no roll call in the minutes.
I didn't see it.
Yep, so we missed that. All right. So we'll make sure going forward we don't miss that again. That was a relatively relaxed meeting, and we did a lot of discussion. I'm sad that you guys didn't get to it because we did get a chance to just have discussions among us in a not as formal situation, and it
Oh, I
it was
completely
good.
agree. If I could have been there, I would have.
I know.
I have, my job just does not allow for that on a Monday.
I know you're not allowed to, you're not allowed to.
And you would not have wanted me to be there. I was contagious and not very good.
Yeah, no, we don't want sick people there.
Yeah, it would not have
And
been fun.
Anthony was gonna be there and then had to not.
We're starting a few jobs maybe on the project.
Yeah, he's the boss, he has to do those things.
And we want working
So,
people.
okay. So, there is nothing more on Measure B. I think Dr. Miller did a great job of doing that. Our Vice Chair, Mo, do you have anything you want to contribute?
I do want to contribute something. You know, as a member of this board and a member of several other boards, I was just thinking about the challenges of public perception that we face in our community, and especially when it comes to county contracts and service provider contracts. And it's really challenging, I think, you know, for you all, and I would say for myself as a policymaker. We're challenged often on the way that the processes work. I believe that we are following the processes as required with RFPs, and that goes for not only this board and county contracts, but also some other boards that I sit on. And recently, there's been a lot of discussion about the same nonprofit or the same agencies applying for RFPs with the county, and complaints of that. And then there was a new agency that applied for an RFP and was awarded that RFP, and there are complaints about that too. So I think it's important that we have so many agencies and persons within our community that want to do this work and want to serve in the mental health and substance use recovery realm in a variety of ways. And I just think it's important that we continue to challenge each other to have productive conversations about how we want the system to move forward together, and this sort of idea of that it's us versus them, or this agency versus that agency kind of thing. It's just not helpful. I think we need a variety of ways to serve the community. Not everybody likes the same, you know, I don't know, styles of things, and so they're having a variety of agencies that are serving our community, I think, is really important. And also yesterday I was at the social services and the probation department were having their state convening for peer-to-peer like responses of social services and probation, and there was an individual there that had been part of the foster care system and then was part of the probation system. and is now a successful, happily married parent that's raising kids in an entirely different way in which they were raised. And I just think that I really appreciate the service providers sharing more anecdotal reports of how the system is working for people, and I wish that there was a way that we had to communicate that better with the public, because I think it really can feel very hopeless when you're deep in that system or that situation where you have a loved one fighting with substance misuse disorder, you have a loved one that's battling the mental health issues, but this idea that there is hope and we do see improvements in people, I wish we would tell that story more.
I agree, especially, well, when Harry Two Feathers were just here, and he said he doesn't see things getting better. And most everybody's starting to see things getting better, so somehow we haven't communicated to whatever way he was looking. So,
I still want to go back to one point with RFPs. It drives me crazy. The one thing that I would like to see is more transparency in the system itself, and I think you would eliminate some of the criticism and the perception in the public. So, I mean, if board members don't get access to that information, let alone, and there are certainly contractual and competitive, boundaries on what you can disclose, but I think that overall we could definitely stand more transparency in those processes, and I think that would help us in the process of overseeing those contracts in the first place, and in second place, maybe in evaluating them.
well, Perry, when you say transparency, that's a
Is a specific word.
when
that
an
becomes
RFP is put out, there are places to go. If you are wanting
I'm
to do
aware.
certain works, then you go to where those are posted. And they can be posted in the newspaper, they can be just announced on, as a public announcement on the radio, and it's on the websites, at
I'm
least
not
for
gonna-
the
I'm
county.
not saying this to litigate it. We've gone
No,
through
no,
this
no.
and hashed it
But
and
but
hashed
it's
it.
as
I'm simply saying
transparent.
that-
Could you let me finish?
Yeah.
It's
Well, you don't
gonna
negate
be
what I'm
as,
saying.
what I'm saying is I believe the way the process works is as transparent as it can be, to my understanding of transparency, but also people who want to do these jobs need to know where to go to find those opportunities. And there are people that want these things spoon-fed, and I'm not trying to say it, I'm just trying to make it just blatant, as opposed to having to go look for them. And I think the RFP that we did, that we did a process, and I thought it was handled correctly. I've been part of 2 of them with this board and Measure B, and I think what we did was as transparent as we could be. If people didn't know about them, then they missed the announcements, or they just don't go look in the places. But I'm finding that what the county's been doing, when I was looking to get a job with the county, I knew where to go to look for it. I didn't get the job, but I knew where to go to look for it. And I'm glad I didn't get the job in hindsight. So, I don't think things are as dire as they
That is
seem.
your
I
opinion,
think.
Joe.
Pardon me?
That is your opinion, and
It
you are
is.
entitled to it.
So, and
Sorry,
then-
I didn't mean to open this can of worms. I just feel,
Yes,
honestly,
it's just-
I feel like we have a lot of really
helpful to
caring
have that
and
conversation.
important agencies in the community. More is not going to hurt us, but at the same time, it's important.
I support
I think
you,
the
Mo.
biggest
I thought that was a
problem right
brief
now is
statement. Thank you.
where our
And
financing
Janine, I
is
think
gonna
you're doing a good job.
be coming
Thank you.
from or
It's
being
getting
taken
better.
away from.
Yeah, it's challenging right now.
Right now, it's really challenging. So, okay, anything more?
No, I'm good.
Sorry about that. Okay. Jennifer, do you have
See,
anything?
I think we're getting better. I don't know. I do. I see growth.
Okay, Jennifer, is there anything that,
No, I don't have anything, but I do have a question. What is the phone number to the crisis line to avoid calling law enforcement for those issues? I'm only asking because we have a neighbor who goes into crisis quite frequently, but we always call law enforcement. And I do feel that it might be a better solution for him, that when those things happen, to contact, because I'm pretty sure he's connected. His grandmother told him he was connected with Behavioral Health.
Yeah, actually, so I actually have all the different crisis lines listed on my phone.
Yeah.
For like the TOR project, all of that.
But mainly ours. They're looking at ours.
Yeah, no, I know. So that's what I would recommend. So the local crisis is, it's a 1-855-838-0404.
And that's also super accessible just with like Google searches and that's on you. Like I think Joe said earlier, we don't have landlines anymore. We don't memorize phone numbers. Pull it up and hit call. That's the easiest way.
And I'm just gonna say, with calling, so I have recently had to call for a family member, and I got crisis. It was on the weekend, so not only did I get crisis, but I got mobile outreach, who then asked me if law enforcement needed to be called.
Okay.
So it was a very smooth process,
Yeah.
and I thought it went really well. And I actually got both of them responded, both mobile outreach and.
Well, I'll save this number to my phone because we've been using the police non-emergent line. He's needed help, and I don't think that's the best solution for him.
yeah, so
Maybe
I've got
we go back to
855-838-0404.
brochure idea
0404.
or a sticker
Yeah,
or
that's what
something
she
to
gave
pass
me.
out.
Yeah, that's
We've
what I have
had
in my phone.
business cards and brochures with the crisis line. I think people just, like Joe had said, it's easy to remember 911. You know, and it's unfortunate, right? Like it's easy to remember 911, so I think that's why a lot of people do that. It's harder to remember 855. You know?
Right.
And so, and then I think sometimes people aren't, you know, in a moment to go, oh, I need to look up the line, you know.
Yeah.
But it is the best line. I don't know if we could ever move to everything that rolled up, but you know, it is the best line. It is supposed to be, you know, if you call that line, it goes to crisis. That is our dispatch. Crisis will do a dispatch. They'll do a kind of a mini like screening to determine whether the mobile team needs to come out or what's the best course of action. If it's determined the mobile team needs to come out, the crisis team will contact the mobile team, and the mobile team will work on it. And the mobile team will ask those questions like, is it dangerous? Do you need law enforcement to make sure they're safe? If the answer is no, they'll come out. The team will respond.
I can attest that number works well.
Maybe we could have a campaign around
Yeah.
putting it in your phone, because that's how I
Yeah,
find it.
that's
It's
what I
just
think, too.
My contacts, I look up crisis hotline.
Yeah.
And as long as it doesn't seem like the number's not changed, so.
It's on the buses.
This-
Did anyone see the MTA
Yes.
buses? They're
Yeah.
It's
That
placard
number's
on the
been
MTA
just
buses
been
right now,
years.
and so we've been trying to get
Maybe
that
we could
number
follow
out
up with
there.
some news articles and just do a little campaign, just to be happy.
Yeah, I just highly recommend like putting it our local, any of them, because I've had to hit out a lot of different ones via, maybe it wasn't appropriate for local, but maybe just a team needed just to be able to text somewhere. And so it's handy. It's handy.
Yeah, I have it in my phone under Mendo Crisis.
How often do the police help refer to your services when they feel that this might be something that they could intervene, or that you would be better intervening in?
It depends, you know, if it's something where we know the client or a client that they're aware of or they know there's no danger, they'll just send our team.
Okay.
So they'll make that decision to send a team, you know, like, hey, sometimes it's like, hey, can you just go out? And then we'll make a call to send 2 people or 1, you know, depending on if it's someone we know, someone we've worked with before, we're less likely worried, you know. But yeah, sometimes they just send us.
That's only when you reach the local dispatch dispatch, not HP dispatch, correct?
CHP dispatch, I think, will connect you to the local dispatch, won't they?
Yeah, it's pretty hard because they're from Reading, and so when I've had instances where I've had to call and they don't know who are people or what area, and it's very frustrating. And then I use the non-emergency number and try to call to get through.
But the local dispatch knows the numbers and everything, so they'll connect. But I guess if it comes out of Reading, they may not. But once the call comes in, the law enforcement will sometimes, once they get the call, if they think there's a mental health thing, they'll call us and say, we need you there. So they're like, hey, we're responding, we need you guys to respond with us. And so then they'll respond. I've had to remind my staff we do not have law enforcement vehicles and we cannot drive law enforcement.
Here's no.
It's a crisis response, however. Still have speed limits. You respond with law enforcement. But yeah, so we get called for a variety of things come out with them. Sometimes they'll go out and then realize they miss and call us out. Sometimes they'll tell us just to go out.
Good to hear.
And I believe that's the same with RCS too. Like it's the law enforcement will get a hold of RCS.
And we have data on that, and I'm happy to write it for the next meeting on how many of our calls have law enforcement involvement. So it's kind of the opposite. Like once we get them, how many came from law enforcement, we wouldn't have how many total law enforcement calls.
Yeah, yeah.
And I've called and gotten Reading, and if you're not in a panic, if you explain to them where you are, they will ferret it out and send you where you need to be. They're pretty good about that. But if you're in a panic and you can't communicate, it will cause them even more confusion.
I'm not in. I'm just impatient.
I know that.
I know if they call another number, I'm going to do that.
but other people would be more in a panic.
Sure. Yeah.
You, not us who are a little bit more educated.
I would say that we have found that going out reduces number of 5150.
Wow.
And that is how we've tracked the number of calls we've gone out on to see how many actually ended up in a 5150 that and it didn't and might have if we weren't there. So we track that and we show it's greatly reduced by having us go.
A much better likelihood of a positive outcome too.
Mm-hmm. I will just say we've had a handful where we went with law enforcement and they were great law enforcement and then we showed up and they lost it. I think they're worried about being hospitalized. That was more scary that we were scarier than law enforcement. But that's a rare occurrence. Usually they're really good, but we've had a lot of where we ended up escalating. So that doesn't really happen, but we can be a little scary too if you want to end up on a psych unit, right?
Everyone's afraid when they're in the middle of a psychiatric break.
I don't want to go to the psych hospital.
If they realize they're having a psych break.
So maybe at some point we could talk about a campaign, just an info awareness.
We could do more. We literally just put them on the MTA buses. So
I love that.
Yeah, they're on the buses. If anyone has seen, we recently put them on MTA. They're on the MTA buses, which has the crisis line. So I know they're on some of our billboard that we've been putting up. But we talk about more of a campaign.
There is a billboard as you leave Fort Bragg on Highway 20.
That's ours.
I know, but it's the most blah billboard. I didn't notice it. My husband did. He goes, "Did you see that billboard? Is that one of yours?" And I go, "What billboard?" Because it's just plain white. It needs to have something on it to make it pop.
It might.
It might just be old.
Yeah, it might be fading because I don't know of any plain white ones we ever have. Sometimes I think they're too dark. Because we have a couple on
I'll take a picture and send it to you.
Yeah, I know which one it is. I just haven't seen it recently. I was just over there to look. But yeah, we do try to update them.
Yeah.
And keep them. But you don't want too much on there because then everything gets lost.
No, but you want the number to pop. And there's nothing about that billboard that I know's popped, because it had to be pointed out to me, and I.
That's your colors.
Tim, have you noticed it? It's near your store.
No, I really haven't.
I feel like it's too dark.
Yeah.
Is that the one on Highway 20?
Yeah, it's on
When you leave Fort Bragg on Highway 20.
I love that one. And I'm like a billboard critic. With the hands?
I don't even know it had hands on it.
That is my favorite one.
I think like.
Because there are many of our billboards I do not like. That, and some that still exist.
All right, well, I'm going to go take a picture. I'll make sure Tim
Not
gets
while you're
it,
driving.
too.
Not while you're driving.
No, I don't do it while I'm driving.
Like if you drive down 101 and the locks on one, the locks, save a life on the locks on. I feel like that's too dark and you can't read it as well.
And it takes you long to understand what it's trying to say.
Exactly.
Like it's
And where is
complicated.
that one?
It's right on 101. There's two.
At the South State Street
Yeah.
exit on 101.
If you go down the two
Oh,
down.
usually I'm looking at that exit so I don't look at the billboards.
Yeah, there's two down that way.
The auto collision shop, you're gonna talk with them about, their sign says, don't look at it too long, you might need us.
It's pretty good, yeah.
There you go. And there's that one that's down there on the north end of town on 101 that was the vaccine one that no one ever, it's just fading.
Yeah.
And no one's ever put one over there, so you can't just take it down.
You have to put one over.
You have to put one over it, yeah.
Yeah.
Gives me an idea for the vaccine, but that's.
Yeah. Okay. So, and Martin's not here, and Lois wasn't here for appreciation. Any other member comments? Okay. Did any of you all came, is there anything that anybody is dying to tell us before next month? I think it's a resounding, okay. We're glad to have you here. All right. Do I hear a motion to adjourn?
Motion to adjourn.
I second.
Okay. I have something for everybody, and I didn't catch Mark. I just saw these